Mr. Chairman, yeah. Thank you very much again for giving me the opportunity to give this presentation on management of bowel ischemia following EVAR and also following open abdominal aneurysm repair. I have no disclosures concerning this topic. The incidence of and outcome, could we stay with, okay. The incidence and the outcome following, we have a problem with my presentation. It runs back and back and back again. So the incidence following EVAR and OR is rare. It is even, it occurs a bit more often after open repair, and it even occurs more often after emergency repair, both for EVAR and for open repair, and accounts to an amount of 23% following open ruptured repair. There are supposed to be specific predictors for this occurrence, including female sex, age, and also blood loss during the procedure. And we also need to face the fact that the incidence of bowel ischemia following these procedures is not decreasing so far. In addition to this, the diagnosis is not easy to perform, although the urgency is very necessary here. As we were able to show in the current guidelines on the management of diseases of the mesenteric arteries and veins, we know since then at least that D-dimers are highly sensitive, but they almost completely lack specificity. And there are no other reliable plasma markers for acute mesenteric ischemia. And even lactate is early metabolized by the liver and only elevated in case of bowel ischemia. So diagnosis largely relies on clinical investigations like colonoscopy, CT angiography, laparoscopy, and laparotomy. There is a caveat concerning previous abdominal surgery. These patients certainly do have a higher chance to develop bowel ischemia following AAA repair. As you see here in this right case, this was a patient following sigmoid resection. So the question is, are there any additional predictors for the occurrence of bowel ischemia? Can additional techniques avoid this? And how are the outcomes following colonic ischemia, even in the long-term run? To answer these questions, we performed an investigation using German health claims data, including 9 million members here, and we looked for all elective and ruptured cases treated for abdominal aortic aneurysms in a 10-year period. The baseline characteristics of these all over 9,145 patients with 79% out of them being males show that there is a difference between EVAR and open treatment, both for elective treated cases, these are the left two columns, and the ruptured treated cases, these are the two right columns. And again, there is only one difference in terms of significance concerning male patients and the von Wallraven comorbidity score, which is highly predictive in favor for EVAR for EVAR patients. The in-hospital outcomes show very consequently and very similar for both elective and ruptured cases, that there are highly significant incidences and differences in terms of acute renal insufficiency, respiratory insufficiency, other complications like pneumonia, in and out hospital, more early mortality of up to 90 days, and also total length of stay and postoperative length of stay in these patients. If we compare those patients with and without colonic ischemia following these procedures. And interesting to know or to realize is that the immediate follow-up of these patients in terms of mortality show that patients receiving or developing colonic bowel ischemia do have a very decreased increased mortality rate with a decreased survival time, both for elective cases and also for ruptured cases. These health claim data give us the opportunity to even look for the long-term run of up to 7 years here. And here is interesting to note that even in the long-term run, the incidence of mortality is increased over the long-term run in these patients developing colonic ischemia in the perioperative course, both the elective ones and also the ruptured patients. Looking for independent predictors of occurrence for colonic ischemia, we were able to realize that there are some independent predictors like rupture, like von Wallraven comorbidity score, which is highly increased in these patients with colonic ischemia. EVAR, in contradiction to this, is highly protective, and age and also sex, obviously here, at least using these data, don't show any significant differences here. If we stratify these independent predictors for elective and emergency repair, we again realize that this Wallraven comorbidity score is highly sensitive and significant for this occurrence, both in the elective and also the ruptured stage. And also the use of EVAR is again protective in this stratification. So I come to my conclusion, and I would summarize that post-AAA repair colonic ischemia, fortunately, is very uncommon. However, if it occurs, it is associated with worth 30-day and also long-term survival. EVAR is protective both for elective and also emergency repair. And further studies, however, may focus on predictive scores and additional preventive techniques. So to conclude by Shine's talk, it is merely impossible still to increase mortality following colonic ischemia. Thank you very much for your attention.